Well, have you or someone you known been recently diagnosed with ovarian cancer and your doctor was talking to you about surgery? Then today we're going to talk about primary debulking surgery. If that sounds good to you, please continue watching. I'm Dr. DuPont. I'm a board-certified gynecologic oncologist, and I'm passionate about educating women to live longer and healthier lives, and I believe that begins with great health. I've done several videos on ovarian cancer, fallopian tube cancer, and actually ovarian cancer staging surgery most recently. My whole purpose of going through all of this is just so that you understand some of the terms that we'll be talking to you about, because I know that when you're diagnosed with cancer, there's just so much to learn and it's overwhelming. I did the video on staging surgery, and so those are for patients that have very little disease. Let's say we did a biopsy, or, I think one time I had a patient that, had gallbladder surgery. She had a gallbladder removed, and they saw something in the pelvis and they biopsied it and it was ovarian cancer. So she had a staging surgery because she had very low volume disease. And so the staging surgery is very specific, where we do very routine procedure to be able to remove all the cancer we can see, and also hidden cancer, to be able to give a patient a stage. Well, primary debulking surgery is very similar. Typically, when we say primary debulking surgery, you have like a big pelvic mass, whether it's an ovarian mass or, a mass in your pelvis that needs to be removed. Let's say they have disease everywhere. They have it all in their abdomen. They have it in the upper abdomen. They have it in the pelvis, disease in the lungs. Then you may have what's called a interval debulking surgery, where you have chemotherapy first, which we call neoadjuvant chemotherapy. Then we do surgery called an interval debulking, because we kind of do it in the middle, and then you'll get more chemotherapy later. So if you have widespread disease, or if you're very frail, let's say you're older and you're just not in good health and a big surgery would be too harmful for you, you may have neoadjuvant chemotherapy and interval debulking surgery, and then we call it adjuvant chemotherapy, or after surgery you get more chemotherapy. The patients that have disease that we feel we can get all of it out, we do a primary debulking surgery. And so very similar to the staging surgery, the debulking surgery will first remove the bulk disease. So all of the big masses that we can see, and if we palpate anything abnormal, we take all of that out. And so this procedure, this primary debulking surgery, was first discovered by Joseph Meigs in 1934, but it wasn't popularized or became widespread until 1975, when Griffin published his article stating that if we removed the bulk disease, or the big masses, patients actually did better and lived longer. So when he published his study is when this type of surgery became wildly popular. So we all give that acknowledgement to Griffin's. I actually wrote a paper on ovarian cancer many years ago when I was a trainee, and actually read the original paper from 1975. It was amazing how much data he put in one paper, but it was a great study that's still available today. Definitely helped kind of turn how we think about ovarian cancer surgery. And so one of the conclusions that Griffin showed is that if you're going to do surgery for ovarian cancer, it's kind of almost all or none. You want to get all of it out. And so we used to term, or we still do, optimal cytoreduction as being no disease left behind that's more than 1 centimeter. So when I was in training, I was a resident or a fellow, our goal for an ovarian cancer patient, if we were doing primary surgery, was to get all the disease and leave less than 1 centimeter behind, because we knew that patient would have the best success rate if we could remove all gross disease. Now, Griffin's did show that the more tumor you left behind, the more likely the patient wasn't going to have the best outcome. And so our goal now is to get no visible residual disease. So, you may read your report in Epic or in your chart that says no visible residual disease. All that means is that when the surgery was complete, you had no more disease that the surgeon could see. Doesn't mean you didn't have microscopic disease that could be found under the microscope by our pathologist. It just means that that surgeon removed all the cancer that they can see. And so we do know that if that is able to happen, you do have the best outcomes. Now, we do know that in terms of surgery, it's not always dependent on the hospital system you go to or the surgeon that you see. Sometimes it's the tumor biology. We don't always know why some tumors are more aggressive than others, but we do know that the biology of the tumor, where that tumor is located, sometimes will make it very difficult to be able to get, an optimal cytoreduction, or to remove all the cancer that we can see. because it's just the tumor is just very aggressive. So just keep in mind that tumor biology does play a part. Another thing that plays a part is just the patient's health status. If I have someone that's very old or very frail, let's say someone that just has very bad heart disease or lung disease, a lot of times we can't do these big operations because these operations, take longer. They may have more complications. And in someone that's very ill or frail, they may not be able to tolerate, 4 or 5 hour surgery. They're just not healthy enough. And so for those patients, we don't do primary debulking surgery. Those patients probably will have an interval debulking surgery if they have surgery at all. Now, for ovarian cancer, we do believe that surgery is important, but it also is just one of the factors in how we treat patients. So, if you're someone that maybe, or your family member is frail or in their 90s or upper 80s, they may not be able to have this primary debulking surgery. And just because what we do in surgery, there's different levels of risk, and we want to make sure that we're looking at the risk benefit ratio when we're offering patients treatment options. So I wanted you to be able to understand what primary debulking surgery is. If you have had primary debulking surgery and you want to share your experience with others, please put them in the comments below. Thank you for watching to the very end. If you want to see more videos on ovarian cancer, just put it in the chat. Please make more of these videos. Please look at some of my other videos that I did last year on ovarian cancer, fallopian tube cancer, and then some of the different types of surgery. I think you'll find this very helpful. And I'll see you in the next one. Bye-bye.